The worst category on this chart is I have poor community health supports, I have poor well-being, and I have disease. You see, now I've generated 8 categories here. In population health management, the systems are frequently based on 7 or 8 categories, which would be very much arrayed just as I'm showing you here. And we need to do work in behavioral health and better understanding how these 8 categories actually operate and what are the mechanisms by which community health determinants influence well-being and influence our disease status. Huge importance to doing this work. And again, I think in behavioral health, we're a little bit behind on this work. I think the Centers for Disease Control is ahead of us in other health areas like arthritis or in epilepsy. So if you look at some of the work in those fields, you'll see that they've done a lot of work in these particular areas. So some of the key principles we would want to take away, these are all public health principles. Always better to prevent something than to treat it. Always cheaper to do that. It's always better for a person's well-being to do that. Better to treat earlier rather than late. We've learned with first episode psychosis, if we treat psychosis in the first episode, we can actually prevent it from becoming severe. We can't prevent the psychosis, but we can prevent it from becoming severe. Always better to intervene with populations rather than individual persons. And finally, always assess effects, measure outcomes, and measure performance, basically. Key public health principles here. So what are some of the implications of all of this? We want to move toward person-centered care, the way that I was talking about it a few minutes ago. If we have person-centered care, that implies integrated care, and integrated care implies that the care is available concurrently to people. Not necessarily sequentially, it's available concurrently. Care must also address all the levels, the community level, the well-being level, the disease level, must address prevention and promotion, and must address population differences. I know that's a huge mouthful, and I could spend many hours talking about this overhead, but I need to go on here. Okay, some practice implications. So there are basically 3 models of integration that we've had in behavioral health. The original one, model 1 on the top, is the classic treat-refer model. You come to behavioral health. I say, well, this person needs other care. I'm going to refer them somewhere. I refer them. What happens? Do they get there? You're shaking your head? No, they don't get there. No, the majority do not get there. They never appear there. So even if I treat and refer and am very careful about the referral, the person never arrives at the referral. We have many studies in NIMH that date back 20 to 25 years that documented this very well. So we knew 25 years ago that this was a major problem. Out of that, we then evolved what's called bidirectional integration, which is the second model here. I guess the best way to view that is to have 2 practices that sit right next to each other in the same building, in rooms that are literally adjacent to each other, where I as a provider can walk you over to my colleague in another office who is the primary care physician, and vice versa. So we moved a little bit toward what we call bidirectional. One variant is bidirectional integration, where we co-locate offices. Another direction of bidirectional integration is what's called co-occurring care. Co-occurring care, which is a kind of a souped-up version of treat-refer, basically. Then there's a third model, which is full integration, where medical and behavioral health practice is fully integrated and financing is fully integrated. So where we are now pretty much is somewhere in model 2 here. And struggling with Model 2 right now. And there's some other little factoids on here, and I'll come back and talk about them in another overhead here. So I'm not going to go through this in detail. This is a little table that you can use to analyze where your program is in the evolution toward integrated care. You can analyze the problems of access, integrated care delivery, payment, and outcomes. And you see model 1, 2, and 3 on the top. They refer to the 3 models that we were just talking about. And you can score your own programs. I encourage you to take this little table home, sit down with your staff, and not just your senior staff, but also your clinical staff, your meet and greet staff, and go through this. Say, where are we? Are we mainly in Model 3? Are we mainly in Model 2? Are we mainly in Model 1? Where are we? This can help you identify areas that will help you move toward integration. Okay, another important thing. So, if we look at the world of behavioral health today, about 75% of all behavioral health patients are seen in the primary care sector. Only 25% are seen in the behavioral health sector, which is what this overhead makes the point at. If I then look at where our practicing behavioral health providers are and our practicing medical providers are, you see a couple other little factoids. Less than 5% of all practicing behavioral health specialists are actually in the primary care sector. Less than 5% currently. Less than 1% of all practicing medical specialists are in the behavioral health sector. So if you were a young person coming to me and I'd say, where are the opportunities going to be going forward? And you were a behavioral health person, what would I tell you, basically? And there's a lesson in that for us. The lesson in that for us is we need to be very careful of losing our own expertise and our behavioral health staff to the primary care sector, to federally qualified health centers, as an example. We need to pay very close attention to that because we currently have a human resource crisis of our own. And then the other reverse issue is what can we do to recruit people from the primary care sector to work with us? So I think these are questions we need to be asking ourselves here. I'll show you this. There's lots of numbers on here. You can look at this, and I'll have a few questions for you at the end of the presentation on this table. So all I'm going to focus on is the bottom 3 rows. Hopefully the numbers are big enough that you can see them. And there's a couple of very important facts here. So if I look at the mental health SUD row among the bottom 3, no mental health SUD in total. Mental health SUD, $508 billion for medical care, not for behavioral health care, for medical care for people who have behavioral health conditions. $82.203 billion for behavioral health care, $113 billion for medical prescriptions, and $48 billion for behavioral health prescriptions, for a total of $751 billion. $750 billion a year is spent upon people who have behavioral health conditions. And you see the exact distribution. The only numbers in the whole chart that aren't there are the expenditures in Medicare for medication. You see the NAs in the table. Those numbers weren't available. But every other number, the numbers are very complete. So if you then look at that and you say, well, of the total medical care in the United States, a third of the medical care in the United States goes to people with mental health SUD conditions. $508 billion versus $1.2 trillion. Medical pharmacy, $113 billion of 202. Again, a third of medical pharmacy goes to behavioral health clients. what makes these numbers virtually astonishing, so then you step back and say, well, in the behavioral health system, we're only serving about 40% of people who have these conditions. The other 60% are not ever reached by the system. What if we actually reached everybody? Where would we be in these numbers? These numbers are astonishing numbers. I can't use any better numbers to make the case for integrated care. If we had integrated care, I expect we could do something about that $508 billion, $535 million spent on medical care for people who have primary behavioral health conditions. So there's huge utility of these kinds of numbers for your use here. Okay, going back, so if we kind of then fast forward, I told you 75% in primary care, 25% in behavioral health. If we go forward 10 years, we would say in 10 years, it's going to be about 90% of all behavioral health clients are going to get their care in the primary care sector, and about 10% are going to get their care in behavioral health settings. And for the most part, that is going to be in public behavioral health settings, such as are run by LA County, such as many of you work for. And the private sector is going to gradually move over into the primary care sector. So I think another thing to think about is integrated care evolves for you and the counties evolve. How are we going to cause that evolution? How are we going to staff it? All these types of questions which become very, very important. Okay, some emerging challenges here. Come as no surprise to you, behavioral providers have a fundamental fear of integration. Losing your job, losing your organization. Be no surprise to any single person in this room. You have to address these fears before integration can fully proceed effectively. So I used to do a lot of, when the Affordable Care Act came out, a lot of workshops on integrated care, and I would go and talk, and people were never focusing on what I was saying, and part of the reason is they weren't hearing a single word I was saying. What they were hearing is, I'm going to lose my job, or my organization isn't going to be there after this Friday, basically. So you have to address those things, and if you start thinking about them, I would argue nobody's going to lose their job because we are just totally unable to meet the demand. Cannot meet the demand with the current staff we have. So that, you may not be working for a different organization, but you're not going to lose your job in this deal, especially if you do good work. You're probably not even going to lose your organization because even if your organization disappears, it's going to be integrated into some other organization. Its capacity is going to get integrated. So it's not going to disappear really either. But you got to work those things through for yourself. And I guess the second factor is realizing that full integration is really very complex. You don't go to graduate school, learn an evidence-based practice, bring it to your organization, and then have integrated care. It involves all kinds of sociology, organizational development, on and on and on and on and on, if you do full integration. And then you need to recognize we're not taking on something that you're going to accomplish in 5 minutes or probably even in 5 months, basically. It's complex. I mentioned this before. I'm going to skip over this. Huge issue of opioid deaths. Everybody in this room recognizes this chart. Look at that chart for synthetic opioids, fentanyl and so on. Amazing, just amazing. And probably not a single person in this room who doesn't know somebody who's died of an opioid overdose. Tragedy, tragedy for the United States. Prevalence of opioid use among persons with mental illness. And I'm going to read these. Among the 38.6 million Americans with mental disorders, 18.7% or 7.2 million persons use prescription opioids. 1 in 5, basically. Adults with mental disorders receive 51.4% or 60 million of the 115 million prescriptions of opioids distributed in the United States each year. So over half of the opioids prescribed go to people with mental illness. Half. Compared with adults without mental disorders, adults with mental conditions were significantly more likely to use opioids. 18.7% versus 5.5%. It's almost 1 to 4 times as likely, basically. And we know some of the reasons. If you have somebody who has depression or anxiety, that person is going to be much more likely to have pain and much more susceptible to pain. If you're more susceptible to pain, you're going to be more susceptible to having prescription opioids. So it should be no surprise to us that these factoids are true here. Now, a couple more. Persons diagnosed with depression or anxiety disorder are about twice as likely to suffer also from a drug use disorder. Persons diagnosed with drug disorders are roughly twice as likely to suffer also from depression and anxiety. And in a sample that I examined here, 10% of more than 10,000 patients prescribed opioids developed depression after using the medication for simply a month. They're getting secondary depression literally a month. So these are astonishing numbers. So in terms of integrated care, what is the huge implication of all of this, basically? Prevalence of each is very high. Causality is bidirectional. Probability is very high that persons will suffer from both. Mental health and substance use care must be available concurrently for this population. Treatment of depression and anxiety is a preventive measure for opioid use and addiction. And vice versa. So we need to figure out how we can do a better job of bringing this concurrent care to this population. I would argue if a person has depression and we don't pay attention to the fact that that depression can go on to opioids, we're missing the boat here. As a field, we're missing the boat. So we have a huge amount of work to do with this, and hopefully you'll be able also to talk more about this as you go through the program here. Just a few words on care reform. I did write a summary, cliff notes of the Affordable Care Act when it was passed, so if you haven't read those cliff notes and you want to read them, they're available in the link here. ACA provides for the creation of integrated health homes, which offer care as well as prevention and promotion. The health homes are created through the Affordable Care Act, Section 2703. And they create accountable care organizations set up to implement and operate medical and health homes. They can be set up and operated out of the health sector, or they can be set up and operated out of the behavioral health sector. The benefit of Section 2703 is that it gives you an accelerated rate of Medicaid payments for 2 years while you're setting the system up. So you get 8 quarters of accelerated Medicaid payments. A couple other things, rapid shift towards self-directed managed care. If you have a capitated system, I don't need to be evaluating your work encounter by encounter because you're going to be managed by your capitated amount. You have to manage yourself, I mean by self-directed managed care. And integrated financing. There's an enduring concern with cost, an emerging concern with well-being and well-being models, as I mentioned before. The goal is recovery, health, and active, engaged community lives. Peer movement has come fully of age. Recovery is an essential care motivator. So if you're a peer, recovery is a huge motivator for you. And we need to recognize that. Weakening and integration of state mental health and substance use agencies into health, Medicaid, and strengthening the state Medicaid. So that's already happened. You were the poster child of that change in California. So when the mental health agency and the substance use agency disappeared into the health agency in California, I believe you were the first. Health entities are in ascendancy here. So all things to be thinking about that I can't really go into. Personal level, important here. What role do we play in integrated care systems in promoting people's health literacy about their own health and well-being. And then how do we translate that health literacy into health activation where they can become more engaged in self-directed care? At the community level, what effects does the community have? How do we become literate about our community? So when you go home, you say, well, I live in one of those zip codes where it says I'm going to die at age 62. What are you going to do about it? How literate are you about what's going on in that zip code? That you can actually become engaged with the county council, you can become engaged with the county public health department, et cetera, on those issues. And then finally, creating activation, public and population health interventions. So very interesting, it says, it's a health first dilemma. You've got a rare condition called good health. Frankly, we're not sure how to treat it. Okay, looking toward tomorrow, some new things. So, our challenge here, how can we foster the development of integrated care without losing many of our providers and our counties and everybody else along the way? So, several things that I think are very interesting. So, how do we ease the problems of care integration I've been talking about? So, Dr. Marcy Reese, who's a new DSW at USC, has developed a model and platform for virtual care integration. It's already up and running. And the example here, we would have a behavioral health provider present virtually in the encounter with a primary care physician, or vice versa. We no longer have to actually match the organizations together and do all these things. Substance use care office, mental health provider is present virtually in the encounter with the substance use specialist. Same kind of thing. These platforms already are up and running. She's a very good example of someone who has done this and has developed it, and she actually now has some national sites in operation. Another way of easing, so one of our problems here is because we have not worked together with primary care, we don't know how to work together. We literally don't know how to work together. So another student at USC, Amy Rochland, new as DSW, she has developed a joint practice-based training model to train psychiatrists and primary care physicians, not in an academic setting, but in a practice-based setting. And she's right down the road here at the University of California in San Diego. And so, we need psychiatrists to understand that when you encounter behavioral health clients and you have somebody who has heart problems, the high likelihood that that person is at risk of dying of heart attack or stroke. And what you do about that, basically. And vice versa, primary care physician learning the relationship between depression and heart attack or stroke. Easing the link with social services. Secretary Alex Azar has recognized the importance of the link between social services and healthcare with the basic idea. If you don't do social services, you're probably wasting a lot of healthcare money. Classic example, if I have a homeless person living out under the bridge in the middle of winter, and the person has pneumonia, and they come for treatment of pneumonia, what reason do I have to believe their treatment's going to be effective if they go back out and live under the bridge? Classic, basically. So, as a result, CMS has eased the controls on linkage between social services and Medicaid expenditures. If you are not into that, you need to find out more about it and get into that. And we need to build these links. We need linkages with housing, we need linkages with job supports, and so on. A little bit about 1115 waivers you see here in the center. Most of the 1115 waivers that are done by CMS focus on behavioral health. This says there are 27 in operation, there are 13 more pending. And it compares the behavioral health waivers with all the rest here. The IMD sub-issue and the IMD mental health issue. California was the first state to actually get a breakthrough in the IMD issue for substance use disorders And I want to thank Tom Traven for actually writing the sentences in the IMD application that ultimately got approved for that purpose. So you were the poster child for that. Now there are many states that actually are doing that. We also have finally had a breakthrough on the use of IMD funds for mental health. So you need to know that an opportunity exists on that side as well to use those funds for community-based residential services other than hospitals. And here it basically says all 21 states with approved IMD waivers to date have authority to use funds for IMD SUD. One state, Vermont, has waiver authority for IMD mental health, and as I said, there could be many more. Social determinants of health, North Carolina has one of these waivers on social determinants. I encourage you to look at that and see what's going on. And their particular pilot will address housing instability, transportation insecurity, food insecurity, and interpersonal violence and toxic stress. So, encourage you to look at that. Uncompensated care pools, I believe California has some uncompensated care pool waivers. If that's relevant, look at that. The current legislation on disproportionate share payments for hospitals in Medicaid and Medicare, I think expires in 2021. So we're living on borrowed time. It's supposed to expire in 18. It didn't expire, it got extended. Now it's going to expire in 2021, which means there will be no disproportionate share funds to pay for uncompensated care services in hospital emergency rooms whenever that legislation finally expires, unless it gets renewed. So when that happens, we need to have an alternative to that. And uncompensated care pools represent one possible alternative. Easing the link with public health. I was very glad to see this conference is supported by mental health, and also public health, including SUD, because we need to be doing much closer work with our public health colleagues. Public health needs to adopt behavioral health practices in its models, and we need to adopt public health practices in what we're doing. SAMHSA has done some work to bring these things together. If you don't know about that work, I encourage you to actually look at it here. So some planning questions going forward here. How are you addressing your fears about integrating mental health, substance use, and primary care service? What are you doing about that? What steps are you and your organization actually taking to prepare and implement integration? Are there any new partnerships, any new technology? Are you into the new technology of virtual care? I just did a blog the other day on virtual care. If you haven't seen that, I'll be happy to send that to you. How are you addressing social services as part of this problem? I call that the integration of everything. What changes in vision, strategy, tactics do you think will be necessary to accomplish integration in the short term and in the longer term? As we move from 75-25 to 90-10, how are we going to make the adaptation? So what could you expect if we were beyond some of the issues we have today? What can you expect? It says, Dr. Seuss, you're off to great places. Today is your day. Your mountain is waiting, so go on your way. What would you expect? Obviously, length of life will increase for these populations if we actually address their chronic physical conditions. They won't be dying at age 42 and 52. Disability will decrease and community tenure will grow. Another way of saying that, recovery will grow. A full life in the community will be possible. That's been a dream of some of our peers and consumers for decades in their life. We also would expect the implementation of prevention and promotion protocols to improve personal and population health for people who do not have illnesses. Community life, at the community level, greater attention will be given to the social and physical determinants of health. More community participation will occur in addressing local health issues. As a result, less stigma will occur in the community. And there'll be finally much greater recognition that all health and healthcare is local. When you have a health problem, you don't go to see Donald Trump or the Congress or Secretary Azar. You don't go to the state. You go to your local county or your local community. And they are your care entity of last resort. All healthcare is local, including behavioral health. Takeaways here for you. We're on the right side of the issue. We do have services that can decrease disparities in health status and promote equity in health and well-being. Our clients can and will become happy and productive citizens. So which way will it be for us on integrated care? So I would say your whole meeting is about talking about which direction you are going to go in and encourage you to have that conversation. So one final little story that I just heard the other, it's an interesting little story. So there was a man on a beach picking up starfish and throwing them into the water. A woman came running by on her run in the morning. And she said, well, you know, why are you doing that? You know, the sun's going to come out in a few hours, and, you know, all of these starfish are going to die. Why are you wasting your time throwing these starfish into the sea, one starfish at a time? And the guy picked up a starfish and said, because it's meaningful to this starfish. Because it's meaningful to this starfish. And I think that's the kind of attitude we in behavioral health care have. Because it's meaningful to this person. And I think that's why all of you do the wonderful work you do. You don't get rewarded, you don't get thanked nearly enough, but you do the wonderful work of helping that starfish, basically. So thank you very much.